Okay, good morning. Today I'm going to present on gout. So I will start with definition first lah. So what is gout? So it's an inflammatory arthritis which caused by intra-articular monosodium urate crystal deposition lah. So definition wise is it's a hyperuricemia that leads to crystal deposition lah. So what is the specific one is for gout is monosodium urate crystal lah. So the epidemiology wise demographics usually recurrent attacks in men aged of 40 to 60 years old lah. So and the anatomic location usually it will attack the lower limb podagra, so we call it as podagra arthritis attacks of the great toe lah. And then it will the crystal deposit usually at the ear helix, eyelid or olecranon and Achilles tendon lah. So I will talk about this classification based on etiology. So there is primary gout and secondary gout. So this primary gout usually will be hereditary like Lis-Nehan's syndrome. For secondary gout is any medication or condition that causing that gout. So that is by secondary gout. So for usually for primary gout, okay, how the pathophysiology is a dysfunctional of the nucleic acid metabolism which causes hyperuricemia. So what will happen is that the monosodium urate crystal will be deposited in the synovium of the joint and will cause the inflammatory response to activate, and it will release this four things here: protease, prostaglandin, leukotriene B4 and free oxygen radicals lah. So free presence of uric acid crystals does not exclude septic arthritis lah. So by presentation wise, how they will present to us is by symptom of pain in the joint, and also can resemble septic arthritis lah, and symptoms of renal stones. From the physical examination, they will have a decreased range of motion due to the pain, and also from aspiration, joint aspiration we can see a white toothpaste like appearance of the top 5 lah. And from imaging X-rays, AP and lateral of the affected joint, and usually from the X-ray we can see periarticular erosion with the sclerotic overhanging borders lah. Okay, you can see soft tissue crystal deposition also as well, top 5. So from the studies as well, right, from lab, uric acid usually if increase in uric acid does not shows like it has gout lah. Okay, and usually from the aspiration, joint aspiration, so monosodium urate crystals will be thin tapered needle shaped intracellular crystals. So it's negatively birefringent crystals. So compared to pseudo gout has calcium dihydrophosphate deposition in the joint lah, but this one gout usually monosodium urate deposition. So if you want to see about the treatment, there's two actually. I classified to acute and chronic. So when during you have the attack, so what the things that you give is first the NSAIDs or colchicine. So then you can offer them oral or intra-articular or IV glucocorticoids lah. So the chronic gout, what I meant is by after a prolonged period or repeated pain during in 1 year, he have 2 recurrent attacks or more than 2 in a year. So we can offer him allopurinol. So allopurinol we aim to give 100 mg OD and titrate according to the uric acid now. So for the prevention wise, we need to advise the patient whether if the patient is obese, then we advise to lose weight and avoid all the high purine. We need to advise them to take high purine diets and avoid all the low purine diets lah. Okay, that's all.